Hello everyone. This lecture is on non-invasive ventilation. Non-invasive ventilation is a modality of mechanical ventilation that has been in use in anesthesiology and critical care. And recently it has gained more importance and attention and significance during the present COVID scenario, especially during the first wave. So this lecture will cover up the basics of non-invasive ventilation. So let's quickly get into the slides. So the subtopics that I'll be discussing in this lecture will be the principle of non-invasive ventilation, the various interfaces used, the modes of non-invasive ventilation, the contraindications and indications. Yes, I'll be talking about the contraindications first and then the indications, how to set the ventilator parameters, what are the benefits of NIV and the complications, and how to monitor or assess if the NIV trial is a success or failure, and also if successful, how do you wean a patient from NIV? So these are the subtopics that I'll be going through. So before we go to NIV specifically, I would like to share a slide on the escalation of oxygen therapy. So whenever a patient presents with respiratory failure or hypoxia, the patient is in need of oxygen therapy. There are different levels of oxygen therapy or different steps, I would say, which go on an escalating basis. A patient who presents with mild hypoxia, you can start with conventional oxygen therapy. Conventional oxygen therapy, or the COT, means you use simple devices or low flow devices such as nasal prongs or nasal cannulae or oxygen face masks, the simple transparent face mask, which may or may not come with unidirectional valves or reservoir bags with the intention of increasing FiO2. But these are effective only in mild cases of respiratory failure or mild cases of hypoxemia. So if when the conventional oxygen therapy doesn't help the patient, then you can step up to something called high flow nasal oxygen therapy, which is usually administered via a high flow nasal cannula that is attached to an HFNO machine. There is a separate lecture on high flow nasal oxygen therapy. You can refer to that later. Suppose if the high flow nasal oxygen therapy also fails to achieve your goals, then the next option that you have is non-invasive mechanical ventilation. If NIV also fails, the next option is going for an invasive mechanical ventilation, where you intubate the patient and mechanically deliver the breaths to the patient. Suppose the invasive mechanical ventilation also fails, then your next option is ECMO, or the extracorporeal membrane oxygenation, that is done using an ECMO device in specialized centers. So that's about escalation of oxygen therapy. So now, before we go into NIV specifically, let's also discuss about the indications of mechanical ventilation. Suppose if you type the indications of mechanical ventilation on Google, you'll find n number of answers. And also even your textbooks, they'll give you a lot many indications of mechanical ventilation, which is difficult to by heart and then reproduce it as PGs. So I would like to help you by just simplifying the indications of mechanical ventilation. For that, you need to know what are the components of the respiratory system. So the respiratory system is basically divided into two components, mainly the ventilating pump and the gas exchange system. So ventilating pump is which helps in ventilating the patient. So ventilation is nothing but the movement of air or gases in and out of the lungs. That mechanical process is called ventilation. Gas exchange is the physiological process which happens after the gas reaches the alveoli. It goes into the blood as well as carbon dioxide diffuses back from the bloodstream into the alveoli, and also the gases are also transported from the bloodstream into the tissue. So that forms the gas exchange system. So what are the components of the ventilating pump? The ventilating pump comprises of the respiratory control centers in the central nervous system, the brain as well as the brain stem, the spinal cord, and then the connecting nerves and muscles, the muscles which will include the diaphragm, intercostal muscles, and also other accessory muscles of respiration. Then the thoracic cage, which is composed of the ribs muscles and the parietal pleura, and then the pleural cavity itself, which is a potential space. So this is called the ventilating pump. So if any problem happens with the ventilating pump, then the patient becomes a candidate for mechanical ventilation. A very simple example as an anesthetist I can give you is induction of general anesthesia. You give the inducing agent to the patient goes into a state of respiratory depression. So the respiratory control centers in the CNS are depressed. After that, once you ensure that airway is fine, you usually give muscle relaxants to the patient, right? So when you give muscle relaxants to the patient, all the respiratory muscles become paralyzed. So actually what is happening here is ventilation failure. The ventilating pump fails. So then you intubate the patient and you start ventilating the patient either manually using an amp bag, or you use a anesthesia ventilator which is attached to our anesthesia machine. So this is a simple example where I can tell you for ventilating pump failure. So there are many scenarios which happen. Suppose you have an opioid overdosage, the CNS is depressed and the patient is hyperventilating. Again, there is ventilation failure. You have neuromuscular disorders or nerve disorders such as the Guillain-Barré syndrome. There also are muscular dystrophies. There also the patient, when the patient worsens, they go into ventilatory failure, carbon dioxide builds up, and you may have hypoxia. Patient requires mechanical ventilation. Problems with the thoracic cage, a good example would be a flail chest injury, or problems with pleural cavity such as a tension pneumothorax or a massive hemothorax. So these can result in ventilating pump failure. The lung is unable to exchange, lung is unable to expand properly. So in these cases, you may require mechanical ventilation, and also you need to take care of the cause as well. So the next component is the gas exchange system, which is basically the lungs, which consists of the airways and the alveoli. And also it includes the tuft of alveolar capillaries, which is the pulmonary part of the pulmonary vasculature, and the blood in the vasculature, which is nothing but the cardiac output. So any problem with the airways, such as a severe bronchospasm, such as in severe acute exacerbation of a COPD. So in such cases, you'll have to give bronchodilators, and if still the patient doesn't improve, you will have to go for mechanical ventilation. Same with the problem with alveoli. Suppose the alveoli, which are the gas exchange units, get flooded with fluids, for example, as in pulmonary edema or ARDS, then also it is an indication for mechanical ventilation. Problem with pulmonary vasculature, a very good example would be pulmonary thromboembolism, where the entire vasculature is shut and then there is no gas exchange happening over there. So you need to buy time till the clot is anticoagulated or thrombolized. And then the next problem is problems with the cardiac output. If you have a forward pump failure, right ventricular failure, or any kind of cardiac failure, there also mechanical ventilation helps by deloading the respiratory muscles. So these are the indications for mechanical ventilation. So if you know the components of the respiratory system, then it becomes easy. Always remember, any problem with the ventilating pump, which consists of these particular components, or any problem with the gas exchange system, these particular components, any problem with any of these can result in the patient going for mechanical ventilation. So now mechanical ventilation is the process by which you deliver oxygen as well as, you can say, gases at a positive pressure to the airways and alveoli. Arbitrarily, we take the atmospheric pressure as 0, and any pressure above atmospheric pressure is considered positive and something below it is considered negative. So in mechanical ventilation, we usually provide a higher pressure than atmospheric pressure to deliver gases. The gases and oxygen are forced into the airways and alveoli by a machine. So mechanical ventilation is of two kinds, invasive and non-invasive. That's a very broad classification. So in invasive mechanical ventilation, we can use an invasive airway device, such as an endotracheal tube or a tracheostomy tube, to provide positive pressure ventilation to the lungs. Whereas in non-invasive ventilation, we use non-invasive methods such as face masks or hoods or helmets. So these are used to provide positive pressure to the airways and alveoli, and they are tightly sealed at the interface. So as I said, non-invasive ventilation provides positive pressure to the airways via non-invasive devices or interfaces. For this purpose, you can use a portable non-invasive ventilator, the small ventilators, portable ones which you see in the emergency rooms and pulmonology wards, or you can use a critical care ventilator, which is even more sophisticated, which has different modes and which can be finely tuned. And also, unlike the portable non-invasive ventilator, the critical care ventilators are usually work on very high flows of oxygen and air, and they're usually connected to the central oxygen system. So, but be whatever the machine that you use, basically in non-invasive ventilation, you'll be providing controlled or mandatory breaths to the patient, or you'll be supporting whatever spontaneous breaths are already there by the patient. And in some modes, you'll be providing both. You'll be providing controlled breaths as well as you'll be supporting the spontaneous breaths of the patient. So what are the various devices or interfaces that we use? One is a nasal NIV mask, which will cover only the nasal part of the patient. It's a tightly sealed mask, and the mask is then connected to a ventilator to provide positive pressure ventilation. The next one is nasal pillows, where soft cushion kind of structures are partially inserted into the nostrils of the patient. They form a tight air seal, and then this is connected to a ventilator to provide ventilation. The advantage of these masks is that the mouth part is let free, so that the patient will be able to talk and communicate with the caretakers, and also the patient will be able to take his oral medications as well as food. The other interfaces include the oronasal NIV mask, which is quite similar to the anesthesia face mask that we use during pre-oxygenation. So the oral cavity and the nose are included inside the mask, and then positive pressure ventilation is applied to this area. Another is full face NIV mask, where the entire face area is included, and a tight seal is formed, and then it is connected to a positive pressure ventilator. And this, as we saw in the previous picture, is a NIV helmet or hood. This hood was extensively used in Europe, especially in Italy during the first wave of COVID. Most of the pictures that you saw in the media on the news during the first wave of COVID were mostly of NIV helmets and hoods. This was the time it was extensively used. So these masks, namely the oronasal and full face NIV masks, they are of two kinds. It can be vented or non-vented. Vented means they will have small holes or expiratory ports or valves to help the expiratory gases to escape. Whereas in non-vented mask, there will be no expiratory ports or valves. So when you're using non-vented mask, you have to always see that there is an accessory expiratory valve or port which is attached to the circuit, or you should have a particular ventilator where there is a separate expiratory port attached to it. So this is a portable NIV machine. As you can see, it's a single tube circuit. So the fresh gases flow through from the machine through the tube into the patient, and then the mask. It's through the mask that the patient breathes, and whatever is exhaled out, it cannot go out through the same circuit. So here we should use vented mask so that the expiratory gases can be vented out. Or suppose you have only non-vented masks in your ICU, then you have to make sure that you attach a accessory expiratory valve into this single tube circuit. That is one thing which we need to be careful. In case if you're using the critical care ventilator, Then, as you can see in the picture, they have inspiratory and expiratory limbs separate. So you need not worry about venting. So you can use a non-vented tight fitting mask, because whatever expiratory gases are there, they'll be vented out through the expiratory limbs of the circuit. So now we'll come to what the different modes of NIV. We have different types of classification. So let's go through one of the modes of classification of the modes. So the first is timed modes. Timed modes means controlled breaths or assisted breaths will be delivered to a patient at a preset time. Like we set a particular time that a breath has to be delivered in once in 5 seconds or once in 6 seconds. So accordingly, that particular breath will be given at that particular time. So that's called a timed mode. Some are called spontaneous time modes, where the ventilator delivers controlled or assisted breaths at timed intervals, and also if the patient breathes in between, those spontaneous breaths will be supported, and these breaths are called supported breaths. So ST modes will provide both controlled breaths as well as supported breaths. And the last comes the spontaneous modes, in which the patient will be breathing spontaneously. All breaths will be by the patient, and the ventilator will only be supporting these breaths. There's another way of classifying NIV modes. Broadly, you can classify them into bilevel NIV and CPAP NIV. So in bilevel NIV, there are two settings, whereas in CPAP NIV, there is only a single setting. So in bilevel NIV, you have two pressure levels, namely IPAP and EPAP. IPAP is inspiratory positive airway pressure, and EPAP is expiratory positive airway pressure. In CPAP, we have only a single EPAP setting, that is the baseline airway pressure is raised above the normal 0. So bilevel NIV modes are usually T or ST modes, and CPAP NIV is usually a spontaneous mode. So the indications of these two kinds of modes are: a bilevel NIV can be used whenever there is a hypercapnic respiratory failure. Suppose a patient with COPD acute exacerbation comes with CO2 retention. Then in those cases, what we need to do is to let the carbon dioxide get breathed out. So for that, you need to increase the tidal volume and the minute ventilation of the patient. For this particular purpose, a bilevel NIV helps. As you increase the IPAP, the amount of pressure delivered into the alveoli increases. Hence, the volume delivered into the alveoli increases. Hence, the minute ventilation increases, and thereby there is increased carbon dioxide washout. So, the indication for bilevel NIV is usually hypercapnic respiratory failure. The other mode, CPAP NIV, where there is only a single setting to just elevate the baseline airway pressure, the whole purpose is to tether the airway. You have to just keep the airway patent. So a best example would be obstructive sleep apnea, in which the patient sleeps off, a morbidly obese patient sleeps off, his airways collapse and there is no patency. So when you have to maintain patency of the airway, you can give a CPAP, which will keep your airway open. So CPAP is indicated in obstructive sleep apnea. You can also give it in cases of severe COPD or advanced COPD patients who are on home oxygen therapy, where you want to keep the airways open, or you want to keep some pressures above the aorta PEEP, which is already there in the patient, and thereby reduce the work of breathing. In such cases also, you can use CPAP. So mainly bilevel NIV is when the patient is in hypercapnic failure, and CPAP is usually given when the patient when you need the patient to have a patent airway and an unobstructed flow of air. So now let's go into the contraindications and indications. I'm speaking about the contraindications first because the knowledge of the contraindications is very important. You cannot go keep NIV or start NIV for any random patient with respiratory failure. So the contraindications, the main contraindications include respiratory arrest and post-cardiopulmonary resuscitation, where invasive mechanical ventilation is what is indicated. Patient with cardiovascular instability, a poor GCS, patient who is very non-cooperative, those at high aspiration risk, And those with viscous or copious secretions and the patient is unable to cough out the secretions, then NIV is contraindicated. It's also contraindicated in patients who have undergone a recent facial or gastroesophageal surgery, because if you give an IV and if the gases escape into the abdomen, then there is always a chance of anastomotic leaks and sutures giving away. Patients with craniofacial trauma and fixed nasopharyngeal abnormalities are also not candidates for non-invasive ventilation. Also, a patient who has suffered burns of the face and head and neck area are also not good candidates for an IV. A morbidly obese patient who is presenting with acute respiratory failure is also not a candidate for NIV. But a point to be noted is that a CO2 narcosis as the sole cause of poor GCS is not an absolute contraindication for NIV. Suppose a patient comes with COPD acute exacerbation and the PCO2 levels are as high as 80 to 100 millimeters of mercury. The patient will have a poor GCS, but that doesn't stop you from giving an NIV trial. Because as you give NIV and as the patient's CO2 gets washed out, you can always see that there is a dramatic improvement in the GCS. But what you need to be sure is that you need to be sure that this drop in GCS is exclusively due to CO2 narcosis. What if the patient has a stroke or severe hyponatremia, which will take days and months to improve? So in such cases, you cannot use. Such patients will also present with CO2 narcosis, but you need to rule out other compounding factors also before starting the patient on NIV, because even if you wash out the carbon dioxide, the GCS may not improve, and so such patients are at high risk of aspiration. So in such cases, you should not use NIV, but CO2 as the sole cause. So CO2 narcosis, if that is the sole cause of poor GCS, then yes, NIV is indicated. So let's come to the strong recommendations for NIV. So there are two main strong recommendations for NIV. The first one is in those patients who present with acute respiratory failure due to acute exacerbation of COPD. If these patients come with acute respiratory acidosis or acute and chronic respiratory acidosis with a pH less than 7.35, then NIV is strongly recommended. So here bilevel NIV is to be considered if the pH is less than 7.35, PCO2 is more than 45, and if they have a high RR of more than 20 to 24 breaths per minute, despite standard medical therapy with intravenous steroids and bronchodilator inhalations. And if such a patient comes to you and you feel that no, this patient requires endotracheal intubation, mechanical ventilation, then also they say NIV trial is recommended, is to be considered, provided your patient is not showing rapid deterioration like hemodynamic instability, or if the patient is having a severe symptomatic bradycardia hypotension, then there is no point in wasting your time on NIV. You have to directly go for an endotracheal intubation and mechanical ventilation. But otherwise, NIV trial is recommended. There is no lower limit of pH. The recommendations say you use it when pH drops to less than 7.35, but they do not say that a lower limit of pH, there is a lower limit below which you should feel that NIV is inappropriate. But however, the lower the pH, there is a higher chance of NIV failure. So such patients should be closely monitored on NIV, and they should have a rapid access to endotracheal intubation and invasive ventilation. As we discussed earlier, an encephalopathy which is due to only carbon dioxide narcosis, it's not a contraindication for initiating NIV. The second strong recommendation which came as NIV indication is patients with acute respiratory failure due to cardiogenic pulmonary edema. In these patients, you can use either a bilevel NIV or a CPAP NIV. And this should be done along with other modalities of treatment for cardiac failure, such as intravenous diuretics and inotropic support, such as dobutamine infusion. Along with these, if you use NIV, it gives better results. NIV is indicated also in other conditions like immunocompromised patients with respiratory failure, case of advanced HIV infection, that is AIDS, or hematological patients with hematological malignancies post chemotherapy if they are neutropenic and immunocompromised. Then also NIV is indicated. In dyspneic patients who are only for palliative care, especially terminal stages of cancer or other terminal disease states. For example, advanced COPD cases, they are only for palliative care and they are not candidates for invasive mechanical ventilation. In such cases, during an acute exacerbation, you can use NIV. In chest trauma patients such as flail chest or hemopneumothorax, once you should treat the cause as well with intercostal drainage, but then they'll require support with an IV. Also, you can use it to facilitate weaning from mechanical ventilation in patients with hypercapnic respiratory failure. Once you've intubated a patient and you want to extubate the patient, instead of directly putting them on a conventional oxygen therapy device such as a face mask, you can always put the patient on NIV, extubate the patient, and immediately start non-invasive ventilation. Keep for around 24 hours and then wean the patient from NIV. That is found to be more successful and prevents reintubations and extubation failure. The next indications include post-operative acute respiratory failure, and also it can be used to prevent post-extubation respiratory failure in high-risk patients. So there are many indications, or there are many high-risk patients when it comes to post-operative failure, like post major thoracotomy and post major laparotomy cases, patients who undergo diaphragmatic surgeries, etc. So in such cases, you can prevent post-extubation failure. A point to be noted is that it should not be used in the treatment of patients with established post-extubation respiratory failure. You've extubated the patient and the patient is in frank respiratory failure, then you should not try NIV. You should directly go for intubation and mechanical ventilation. And also some selected cases of acute hypoxemic respiratory failure, such as in pandemic viral illness, the COVID-19, which is around. In such cases also, NIV may be indicated, but we still need to get more solid evidence for this. So what are the high-risk patients for post-extubation failure and reintubation? One would be elderly, that's age of more than 65 years, a patient who had a poor general condition or a high Apache 2 score at the time of extubation, say a score of more than 12, cardiac failure at the time of intubation. So when you were intubating the patient, if the patient was in cardiac failure, then you should be very careful while extubating. In such patients, it's always better to extubate the patient and put the patient on non-invasive ventilator and then wean them from non-invasive ventilation. Obesity. This group of patients are also high risk for post-extubation failure and reintubation, and also major laparotomy and thoracotomy cases, as well as surgeries involving the diaphragm. So now let's get into the ventilator settings. What are the settings that you usually see on when you switch on a non-invasive ventilator? The first one is an FiO2, inspiratory positive airway pressure. If it is a portable ventilator, it will be synonymous to the pressure support on a critical care ventilator. And expiratory positive airway pressure, which is synonymous to the PEEP on the critical care ventilator. Then you have respiratory rate, inspiratory time, the flow rate or the rise time. It's nothing but the inspiratory flow. So when you start, set the FiO2 at 100%, and then later you can come down on the FiO2. When you start with 100%. And start with a low IPAP or inspiratory positive airway pressure of 6 to 8 centimeter and an EPAP of 2 to 4 centimeters of water. A point to be noted is that the difference between IPAP and EPAP should be at least 4 centimeters of water for effective mechanical ventilation or for effective flow of gases to and fro from the patient. Now, you increase the EPAP by 1 to 2 centimeters of water increments till all the inspiratory efforts of the patient are able to trigger the ventilator. Suppose if the patient is making an inspiratory effort, but the ventilator doesn't respond to the inspiratory effort, because when the patient triggers, the ventilator has to sense it and then give the breath, right? So if the patient is making an effort and ventilator is not sensing it, that means the patient has not generated enough effort to trigger the ventilator. So in such cases, what you have to do is you slowly increase the EPAP by 2 centimeters of water till all the breaths of the patient are able to trigger the ventilator. And once that happens, you leave the EPAP, or the EPAP is the lower pressure level, right? Expiratory positive airway pressure at that level. Now you start increasing the IPAP, because we've already set it at 6 to 4, right? 4 to 6. So you start increasing it at 1 to 2 centimeters of water up to a maximum pressure, looking at the tidal volume. Okay, if the patient is getting enough tidal volume. And you reach a pressure point where the patient will tolerate that pressure without discomfort. And also you have to see whether there is any air leak. Suppose a patient doesn't have any air leak and is tolerating it without any discomfort at 10 centimeters of water. But when you give 12 centimeters of water, there is either air leak or the patient is saying it's too much of discomfort for me, then bring it back to 10 centimeters of water and leave it there. After that, you need to set the respiratory rate and the inspiratory time if you're using a T or ST mode. You can adjust the flows as per the PCO2 levels and the respiratory rate of the patient. Suppose a patient is coming with high PCO2 and high RR, it's always better to keep a higher flow to compensate. The principle used in adjusting the flow is that when you have a patient with a high respiratory rate, as in respiratory failure, you should always understand that they'll be having very high flows like 60 to 100 liters per minute. So in such cases, whatever oxygen device you apply to the patient should have a flow which is either equal or little more than that, but never less than the patient's own inspiratory flow. We cannot measure it. Only thing is we can at least presume that, okay, patient respiratory failure will definitely have flows above 60. So use a device which can deliver flows above 60 liters a minute. In such a patient, if you give a conventional oxygen therapy device which can deliver flows to up to maximum of 10 to 15 liters per minute, then it is of no use. You're just wasting time. So the ninth step is adjust the FiO2, because you've set it 100%. Now you can adjust it and taper it down as per the saturation monitor, SpO2 on the monitor, or depending on the PO2 levels in the ABG report. And last but not the least, make it a point to set the alarms. There'll be a lot of alarms depending on the ventilator, like the high respiratory rate, low respiratory rate alarm, high tidal volume, low tidal volume alarm, minute ventilation alarms, airway pressure alarms. So make it a point to set the alarms when just after you set you finalize your settings, and then you set the alarm always before leaving the patient side, because a ventilator is more dangerous. A ventilator becomes more like a dangerous equipment for the patient if you do not set the alarms. So what are the benefits of NIV? NIV has got success rates of 80 to 85% as per statistics. It's been found to improve carbon dioxide elimination as well as oxygenation in respective cases. It improves respiratory acidosis. It decreases the respiratory rate. It unloads the respiratory muscles and thereby reduces the work of breathing. It decreases the length of ICU or hospital stay and mortality rate, because if a patient is kept on conventional oxygen therapy, he may not improve for quite many days. So if you put a patient on NIV, he may improve in 1 or 2 days rather than the 5 to 6 days of oxygen therapy via a conventional oxygen therapy device. Also, since no invasive airway devices are used here, you have lower rates of nosocomial pneumonia. You also have lower intubation and reintubation rates, as we discussed, post-operative extubation failure, or even post-extubation failure in high-risk patients. These can be avoided using NIV. And also there is a reduction in the duration of invasive mechanical ventilation. Suppose as there's a patient who's 5 days, almost 5 days on mechanical ventilation, invasive ventilation, and you want to extubate, but you are a bit worried whether this patient will go into extubation failure. So you keep for another 2 days on ventilator and then you extubate. So instead of that, you can extubate the patient on the 5th day. Another 24 hours, you can keep the patient on non-invasive ventilation, and then you can wean the patient of NIV, and you will probably reduce the duration of invasive mechanical ventilation. So these are the benefits of non-invasive ventilation. So what are the complications? You need to know the complications as well. The main complication which happens with NIV is a delay in intubation and worsening of prognosis of the patient. There can be major desaturation and cardiac arrest in severe hypoxemic respiratory failure cases. There can be aspiration pneumonia if you do not carefully select your patients. Sometimes the patient's GCS can drop during the course of NIV and the patient can aspirate if he doesn't have the ability to cough out his own secretions. Patient can go into hypotension because you are providing positive pressure into the thoracic cavity. So when you provide positive pressure into your thoracic cavity, definitely your cardiac output or your venous return into the heart will reduce, in turn which will reduce the cardiac output, and thereby it can result in hypotension. Patient can have pneumothorax, a COPD patient with a bulla, it can rupture with the positive pressure ventilation, which can also result in tension pneumothorax and a cardiovascular collapse. And due to prolonged use of this NIV mask, it can cause pressure necrosis on the face where you have applied the mask with high pressures for long periods. There can also be air leaks, which can be very confusing, as well as it will keep giving you alarms. And also patients can develop claustrophobia. That's a fear for those with fear for closed spaces can find it very uncomfortable. So it can lead to non-compliance. When every 5 minutes they would ask you to remove the ventilator. So that is why I was saying that a non-cooperative patient is an absolute contraindication for NIV. And because of continuous use of NIV for 24 to 48 hours, sometimes some patients do go into delirium as well. So these are the complications of non-invasive ventilation. So now the question arises, when you start a patient on NIV, whether you should use it continuously or intermittently. So now, since we have gone through the list of complications, if you keep the patient on continuous NIV, you will see that there are problems like delirium, claustrophobia, and pressure necrosis on the face as well. But at the same time, if you use intermittent NIV in the initial hours of respiratory failure, it's of no use, because when you give positive pressure ventilation to the patient, the entire physiology of the body changes, right? And then every 1 hour, if you keep shifting between NIV and room air or conventional oxygen therapy devices, the physiology keeps changing and it doesn't make much of it's of not much of a benefit to the patient. Instead, you're confusing the body. So the recommendation is that in case you're using NIV, just use it continuously for at least 24 to 48 hours. Suppose it's a post-extubation failure. After extubation, use the NIV continuously for 24 hours and then wean the patient off NIV if the patient is stable. Patients like COPD acute exacerbations, if they come in respiratory failure, use the NIV for at least 24 hours or at least till the patient's pH improves to above 7.35. That said, we should also be aware of the complications and watch out for the complications that happen with continuous. But this is what is a reasonable method of using NIV, rather than using NIV intermittently for 1 to 2 hours and then taking the patient and putting on conventional oxygen therapy. So when you're using continuously for 24 to 48 hours, it should be disconnected only for providing oral medications or feeds to the patient. And a very good idea would be, when you disconnect the NIV, try to use high flow nasal oxygen or any other nasal catheter devices which will provide a little higher FiO2 while you're giving medications or food to the patient, which will avoid episodes of desaturation when you disconnect NIV. So about monitoring, you have to monitor for complications as well as for the vitals. So it's monitoring is mandatory during the initial hours of initiation of NIV to detect early signs of failure of NIV, because we need to know whether NIV is successful or it's a failure. If it's successful, you continue. If it's a failure, you have to escalate your oxygen therapy into invasive mechanical ventilation, right? So you need to monitor respiratory rate, heart rate, blood pressure, Glasgow Coma score, and ABG, and also watch for complications. So in this context, the HACOR score, HACOR, is a useful bedside tool to predict NIV failure. So the HACOR stands for heart rate, acidosis or the pH, consciousness, which is measured as the GCS, oxygenation measured as the PaO2 by FiO2 ratio, which will be available on your ABG, and the respiratory rate. So these are the components: the heart rate, pH, GCS, PO2 by FiO2, and respiratory rate. And there are different ranges, and for each range, there is a point given. So the score ranges from 0 to 25. And as the score increases, you need to know that the chances of NIV failure increases. So this is a useful bedside tool to predict NIV failure. So when do you call it a treatment failure in NIV? If the HACOR score is more than 5 at initiation of NIV and also after 1 hour of NIV, then there is more than 80% risk of NIV failure, whatever be the diagnosis, whatever be the age of the patient, whatever is the disease severity. If the HACOR score is more than 5 at initiation of NIV and also after 1 hour of NIV, then you have a high chance of NIV failure and you will have to look into further options. Also, treatment failure is also defined as worsening of ABGs or worsening of pH or worsening of HACOR score in 1 to 2 hours of initiation of NIV, or lack of improvement in any of these parameters even after 4 hours of NIV. So the maximum that you should wait for a patient who is not improving on NIV should be 4 hours. After that, you should take a call whether to intubate the patient or not if the patient is a candidate for invasive mechanical ventilation. So this what we mentioned was about the early failure. So now there is another term called late failure, the NIV failure, which happens after 48 to 72 hours of ventilation. Initially, the NIV was doing good on this patient, your HACOR score improved, all your other parameters improved, but after 40 to 72 hours of non-invasive ventilation, the patient is gone into treatment failure. So that's called late failure. Whether it be early failure or late failure, the only treatment option that is left for you is invasive mechanical ventilation. So this is why monitoring a patient on NIV in the initial few hours is very, very important. So now we'll come to the last slide, which is about weaning from non-invasive ventilation. So when you say that the patient, the NIV modality has been a success on a particular patient, you see that the HACOR score improves. That is the heart rate, the acidosis or the pH improves, the conscious level, then the oxygenation and the respiratory rate, these improve. So one thing you need to understand is that PCO2 as such is not a part of the score, because as PCO2 increases, your acidosis will definitely worsen. So that is why in this score, PCO2 as such as an entity has not been taken, but it is the pH which is taken into more important. So as your HACOR score improves, if it drops to less than 5, then that is a very good indicator of NIV success. And once the patient is stable on NIV, an ABG should be done at least once a day. Prior to that, you can do as per the clinical requirement. You can do it once in 2 hours or once in 4 hours to see if the patient is improving or if the patient is worsening. So after that, once the patient is stable, at least once a day, ABG is required along with continuous morning monitoring of the vital parameters. And once you feel that the patient can be taken off NIV, it's always advisable to wean the patient from a high flow from NIV to a high flow nasal oxygen cannula or a non-rebreathing face mask, which will provide high FiO2 and high flows. As I said, any patient with respiratory failure will require a device which provides high flow. So instead of weaning a patient directly from NIV into room air or a conventional oxygen therapy device, always make it a point to wean the patient step by step. That is, uh, NIV can provide flows from 60 liters to 120 liters per minute, or sometimes 200 liters per minute. A high flow device can give slightly lower flows, that is 20 liters to 60 liters. A non-rebreathing mask can give flows up to 20 liters. So as per your availability, try to wean a patient from NIV onto a high flow nasal device or to a NRBM so that high flows can be given and slowly the patient can be weaned off to conventional oxygen therapy device or to room air. So before discontinuing NIV for a long term, you assess the patient's Hacker score without NIV. So without NIV means you put the patient on an NRBM or a high flow nasal oxygen cannula for around 1 hour and then do an ABG, see the vital parameters and calculate the Hacker score. And if that score is not more than 5, then that means if the score is less than 5, then that means it's a predictor that your weaning is going in the right way. So that is how you wean the patient from NIV. So now the clinical pearls, I'll just sum up the points that we discussed. So non-invasive ventilation is a kind of modality of ventilation in which positive pressure is delivered using bi-level positive airway pressure or CPAP, which is a single level positive airway pressure ventilation. The strong recommendations for using NIV are acute severe exacerbations of COPD with respiratory acidosis and respiratory failure due to cardiogenic pulmonary edema. NIV is also useful in reducing post-operative respiratory failure, and also it's been found to be good in preventing reintubations. Also, there are less chances of ventilator-associated pneumonia or nosocomial pneumonia when we use non-invasive ventilation because we do not use invasive airway devices during this. A thorough knowledge of the contraindications of NIV is a must before starting a patient on non-invasive ventilation. About the settings, we have already discussed that we need to set the EPAP first, that is the lower limit first. The difference between EPAP and IPAP should be at least 4 centimeters of water. And you set the EPAP till all the breaths of the patient are able to trigger the ventilator. And you set the IPAP at a maximum level where there is no air leak and when there is no patient discomfort. And also set the other settings such as FiO2, respiratory rate and flows. And also make it a point to set the alarms on the ventilator before you leave the patient side. And monitoring is also a must. In addition to the vital parameters, you have to do an ABG and then come to a conclusion using a Hacker score, which consists of the heart rate, acidosis or pH, conscious level with GCS, then oxygenation ratio, which is depicted by the PO2 by FiO2 ratio and the respiratory rate. A Hacker score of more than 5 means your NIV is failing. There is a high chance of NIV failure. It's only a maximum of 4 hours that you should ideally wait in a patient with acute respiratory failure. If the patient is not improving, the maximum time that you should wait should be 4 hours. And then beyond that, you should take a call whether you should invasively ventilate the patient. Continuous NIV is found to be more beneficial than intermittent use, especially in the first 24 to 48 hours. After that, you can use intermittently with NIV and high flow NIV and NRBM mask. So whenever you wean the patient from NIV, you can wean to a high flow nasal oxygen device or a non-rebreathing mask. So that is about the basics of non-invasive ventilation. Thank you for your patient listening.